Good day, everyone. It's me, Quratulain, a clinical psychologist and a personal therapist. We have been discussing the whole bunch of scenarios and the disorders here lately in our particular course of clinical course of treatment and management in psychopathology. Today, we will specifically be talking about attention deficit hyperactive disorder. So when we have to talk about the classification, or you can say the diagnosis of the childhood disorders, the first thing come in our mind is basically, are there any particular groups in the DSM or particular disorders in the DSM that are specified for the childhood related disorders? All right. So when we are talking about the classification of childhood disorders, basically it's regarding the developmental psychopathology. All right. From our developmental period of time or early development, the disorders that develops at that particular time are included in the developmental psychopathology. All right. Then comes the relationship between children and adult psychopathology. Why is it necessary for us to discuss about certain other relationships of different disorders, the association of different disorders? Why is it so important? All right. It's because there are certain disorders that are all the way unique to the children, just like separation anxiety disorder, just like you can say disruptive mood dysregulation disorder. Yes, they're very much particular about the childhood, but there are certain primary disorders that can develop in the childhood, but they can continue till our adulthood. For example, attention deficit hyperactive disorder is one of them. All right. So, okay. These are the particular disorders that can develop in the childhood and then can continue from till the adulthood. All right. Just like the attention deficit hyperactive disorder, autism, just like the intellectual disability. Those are the disorders that would stay with a person throughout the life, right? So, as like that, there are certain disorders that are present in both children as well as adults, or you can say in adolescents as well as adults. Just like depression, depression can present itself in early adolescence. All right, we would discuss about the depression lately, but firstly, it will be much more easier for you to understand at this level. Then comes why or either DSM have that particular bunch of disorders or specifications of the disorders. If we want to describe that these particular groups are for the childhood disorders and these particular groups are for the adult disorders, then yes, DSM have splitted the disorders into two major chapters for the childhood disorders. All right. The first one is neurodevelopmental disorders. We have been discussing about the neurodevelopmental disorders till now. We had discussed about the intellectual disability. We have discussed about the autism spectrum disorder. We have discussed about the global developmental delay. And today we are talking about the attention deficit hyperactive disorder. All right. As like that, there is another group of disorder that is called disruptive impulse control and conduct disorder. All right. And at that particular group of disorder, we can say that they are basically preoccupied with certain behavioral issues, all right, in the childhood, especially in the adolescence, or you can say the early adolescence, all right. That include the oppositional defiant disorder, that include the intermittent explosive disorder, and the conduct disorder as well. So that would depend on that, all right. So as like that, DSM obviously have been reviewed and revised till now, and it's has been DSM-5 TR. So there are certain disorders who have been lately renamed. All right. So these are the particular disorders that are basically about the childhood disorders. We have discussed the whole group. Then comes to the either there are any particular classification that these disorders are basically having some kind of internalizing or some kind of externalizing factors behind their opinion, or you can say behind their presentation. All right. If there are particular disorder that is having, you can say, an outward directed behaviors, all right, the overt behaviors, all right, like aggressiveness, overactivity, impulsiveness, a very hyperactive response, then it would be externalizing disorder, the disorder that is representing itself in the kind of behavior that is observable. All right, same like that, there are certain disorders which are basically a very inward focused behaviors. All right, they're not directly so much observable for the individual. All right, they're very, kind of like to the person kind of disorders. All right, they are basically internalizing disorders. They would have included the depression, anxiety, social withdrawal, even sometimes psychosis itself. All right, and those kind of disorders who are having are internalizing, you can say, the presentation, they're more common in girls, and as compared to the externalizing disorders who have been very common in the boys. All right, so we were talking about the attention deficit hyperactive disorder. Here we have already discussed that it's externalizing disorder, it's more common in the boys. All right, so we would keep that thing in our mind, and now we would be moving forward toward attention deficit hyperactive disorder. Okay, so basically if I have to describe the image of or the framework of attention deficit hyperactive disorder, I would say a person having excessive level of activity, all right, distractibility, or difficulty in concentrating, all right, having difficulty with the peer interactions. We have another member to join here. So we have started our framework or discussion about the basic definition or description of the attention deficit hyperactive disorder. So we were talking about excessive level of activity like fidgeting, like squirming, running around, do not have a very particular sitting pattern over a period of time. All right. Incessant talk, or you can say a continuous pattern of talk where they can't stop talking. All right. The talk would have a no particular gesture, no particular topic, but they would just be like on the train to talk. Right. Then comes the distractibility or difficulty in concentration. All right, they make very careless mistakes, they can't follow instructions very carefully, they can't follow steps very carefully, they have a very much you can say the behavior of forgetfulness, right? So that is the reason they may appear to have difficulty with the peer interactions, and that is regarding the onset duration of the ADHD, that is the age of prior to the age of 12 years. All right, and according to this whole framework, if this possible framework is actually increasing, or you can say causing the functional impairment in the person, then you can suggest that that particular person is having a problem like attention deficit hyperactivity disorder. All right, so here we have criteria of the DSM-5, particularly about attention deficit hyperactive disorder, where we have a proper or clear a distinction about attention deficit hyperactive disorder for you guys. I will be presenting a much more broad view. So here, DSM-5 have clearly mentioned that a persistent pattern of inattention and hyperactivity or impulsivity that interferes with the functioning or development as characterized by the one or two. All right. So we have talked about the framework here. All right. Excessive activity, distractibility, and lack of concentration. That would be included in inattention, right? And squirming, deep patronized behaviors, fidgeting, running around, that would be obviously hyperactivity. All right. So in case of hypertension, a persistent pattern, all right, not just for the one or two times due to any particular stimulus, but a persistent pattern, all right. So in case of inattention, following are the symptoms that should represent themselves at least for the 6 months, all right. And they would be impacting a person's developmental level as well as social, academic, or occupational activities. So what are those particular symptoms? Often fails to give attention to the details and make careless mistakes. We have talked about. All right. Then comes often has difficulty sustaining attention in tasks and the play activities. Obviously, we have also discussed that they won't be able enough to focus on the lectures. They won't be able enough to understand the instructions, to follow the steps very carefully. Then comes they often do not seem to listen when spoken directly because their mind is somewhere else all the time. All right. They are not able to focus for a very, you can say, a considerable pattern of time. All right. So they often do not follow through instructions and fail to finish the homework or the course or duties in the workplace. That is also because of this particular problem, because mind seems to be somewhere else. All right. So often have difficulty organizing the task. That is because they have difficulty in managing the sequential task to follow the steps. They have that particular difficulty very much, or you can say a lot. All right. So order, or you can say the sequence is not their type of work, right? They have a disorganized work, have poor time management, fail to meet the deadlines because of the same thing. Mind seems to be somewhere else. Lack of absence to follow the particular instructions or the directions. All right. Avoids dislikes or is reluctant to engage in the task that requires sustained mental effort. All right. Just like the homeworks, a task, group task, all right, preparing reports, completing some kind of forms. That is a very lengthy work for them. All right. Then obviously they would lose their utensils, they would use their particular objects over the period of time, just like the glasses, just like their mobile phones. They would always be in a rush to just lose everything all the time, right? So they are very much easily distractible to the external stimuli, all right? Any kind of noise, any kind of talking around themselves can cause distractibility for them, all right? They are often very much prone for the forgetfulness in the daily activities, doing chores, running errands, all right? So we have already talked about this in this kind of scenario, in this kind of framework here. That was the excessive level of activity, all right? Fidgeting, screaming, running around, inappropriate, insensitive talk, all right? That was all regarding that. Okay. So then comes the hyperactivity and the impulsivity. That is the second major criteria for the ADHD. Here is the same thing. 6 or more of the following symptoms persisted for almost 6 months, all right? And have the same impact, like directly causing the negative impact on their social, economic, or occupational activities. All right. So what actually they are? Often fidgets with or tap hands or feet or squirms in the seats. That is basically just like a sound I will be creating right now, and you have to make it understand what actually that is. Yes, that is the fidgeting. All right. Or the tapping around or tapping hands. All right. If they are doing some kind of work, they would just start doing this. All right. Or squirm in the seats. All right. So that is basically talking about that thing. All right. Then comes, all right. Then often leaves the seats in the situation when remaining seated is very much expected. All right. Like long conferences, like the case studies, all right, like whole bunch of class scenario, they aren't able enough to just sit still at that particular place for that particular time. All right. Often runs around or climbs in the situation where it is inappropriate. All right. In adolescent, adults may be limited to the feeling restless, just like a restless leg syndrome. But it's a bit different from that. I'm also discussing about the differential here, which is very much asked in the vivas. In case of restless leg syndrome, and in adults will be facing difficulty or numbness, pain, or you can say tenderness, anxiety in their legs to move around. All right, they are very much conscious about the situation. But in case of ADHD or the hyperactivity, they are basically running around climbing the situation which is inappropriate, and they don't consider it what the situation is. All right, and they don't have that kind of pain or numbness in their legs. Okay, so often unable to play or engage in the layer activities quietly, as like we have talked about, they are very talkative. All right, they are often on the just go on the train mode. Okay, so is often on the go or acting as if driven by a motor, as we have talked about it earlier. So it's been very much described here. Then often talks excessively. All right, the talk is not like an irrelevant or don't have any kind of sense. It's much more less complex than that, because they would have a very much sense, but they would just like to talk a lot. They would just be talking a lot, and like about each and everything around themselves, and they want to be listened. Okay, they just want to have a lot of friends, a lot of mess, a lot of activities to do, but they can't just sit still to perform a whole activity on a very on the go one mode. Okay, then often blurt out an answer before a question has been completed. Obviously, we being a professionals, we have often encountered this kind of situation in the classes or in the schools or colleges, where students will be like blurting out the answer very much prior to the question even. All right, that is kind of like that situation. Even the teacher's question haven't been completed yet. All right, then often have difficulty waiting his or her turns. They aren't able enough to just wait in line in case of tickets for the train or buses or the divers. They aren't compatible with that. Okay, often interrupt or intrude on others, but into the conversation, games, or activities may start using other people's thing without asking. All right. Then we have talked about the prior age group. We have also talked about the developmental period of the ADHD, and the clear evidence have been mentioned here. We have talked about this in our earlier scenario. Yes, the E criteria has to be very much cleared and has to be remembered all the time. These symptoms do not occur excessively during the course of schizophrenia and other psychotic disorder, and are not better explained by any other mental disorder. All right. You have to remember these differentials whenever you are diagnosing a person, even in case of adults with the ADHD. All right. These are the particular specifiers for the ADHD, including the combined presentation. Sometimes it's only inattentive presentation. Sometimes it's only hyperactive presentation. Where a person is not having ADHD, it would be AD, attention disorder, hyperactivity disorder. All right. So you have to mention that it's ADHD, but only with the predominantly only with the inattention presentation or hyperactive or impulsive presentation. All right. Then here comes the severity level. In case of mild severity level, basically few symptoms in excess of those required to make the diagnosis are present. They are not very much actually compromising to the situation. Not all the 6 symptoms are present there to meet the criteria. In case of moderates, symptoms or the functional impairment between mild and severe are present. All right. You can say 6 to 7 symptoms are present, but their scoring or their rating is like 3 to 4 out of 10. All right. In case of severe, many symptoms in excess to those required to make the diagnosis are present. All right. So we have talked about the DSM here. We have talked about the specifiers. We have talked about the combined majority of the diagnosis. Here comes the differential diagnosis. What is the difference in ADHD or the conduct disorder? As we have talked, the diagnosis should be prior to the age of 12 years. And the conduct disorder presentation is very much similar to the ADHD in that particular case. But if when we will be studying about the conduct disorder, we would learn that the age for the conduct disorder is around the early adolescence. All right. So what makes us differentiate between these two? In case of ADHD, more off-task behavior, not the task-oriented behavior, cognitive and achievement deficits because of being off-minded all the time, elsewhere all the time. All right. In case of conduct disorder, it's being more aggressive, act out in most of the settings, anti-social parenting, and the family hostility. All right. These are the reasons for the conduct disorders, and these are the reasons to present the ADHD. All right. These are the particular sets of disorders regarding the associated disorders with the ADHD. ADHD are more oftenly combined with anxiety or depression lately in the early adolescence, basically. And its prevalence is around 8 to 11% in worldwide. And it's, as we have talked about, externalizing disorder, and it's one of the externalizing disorders. So its ratio is more in the male as compared to the female, just like it's a 2 into 1. All right. In case of 2 males, there would be 1 female, or the expectancy of 1 female to have an ADHD as compared to the male. All right. So symptoms persist beyond childhood, and numerous longitudinal studies have also been worked on. So basically, for the girls with the attention deficit hyperactive disorder, the study had been conducted lately in 2006, where ethnically diverse study was conducted on the girls, and a combined type had been found more destructive behaviors than inattention type. Right? Basically, the combined type were found uh, more persistently or more widely as compared to the only predominantly inattentive type. All right. And the comorbid diagnoses were also found with the conduct disorder, oppositional defiant disorders, than the girls without ADHD. All right. Girls having ADHD was found to be more prone towards conduct disorder or oppositional defiant disorder, or you can say the adolescent related problems of the disruptive disorders. All right. So in case of girls having ADHD, it was also found that they would be found very anxious or depressed. they would exhibit neurological deficits also, including poor planning, poor problem solving skills, and may have some symptoms of eating disorder or substance related disorders in their adolescence. All right. When we have to talk about the etiology, or you can say the causes of ADHD, the first one, for every disorder, we would be expecting about some kind of genetic factors. All right. So, in case of ADHD, the basic genetic factors who have been expecting lately are basically the adoption versus twin studies, where it was actually expected that in case of adopted children, ADHD would be more rated as compared to the twins. And it had also been rationalized that around 70 to 80% of the adoption environment was found to be an etiological factor for the ADHD. All right. Then, for the genetic factors, two dopamine genes were implicated to be the cause of um, ADHD. That is the DRD, dopamine receptor genes, and the dopamine transporter genes. All right. They were the two that were found to be implicated for that. Either genes associated increase the risk, or the prenatal maternal nicotine or alcohol use is present. So we have found three genetic factors, two dopamine genes, either prenatal maternal nicotine, and the third one is alcohol use. All right. In case of neurobiological factors, dopaminergic areas were found very much smaller in the children with ADHD, specifically in the frontal lobes, caudate nucleus, and the globus pallidus, right? Then the poor performance on the adult test of frontal lobe functions were also found. Then here comes our next developmental period, that is the perinatal and prenatal phase. What is the perinatal? First of all, you have to understand this. Prenatal is prior to the birth, all right? Not regarding the birth, it's prior to the birth development. During the pregnancy, the baby grows, it's regarding that particular factor. In the perinatal, we are actually talking about during birth scenario, all right? So a patient or the child having low birth weight can be mitigated or expected to have some kind of proneness for the ADHD. All right. Maternal tobacco or alcohol use can be the cause of ADHD to be developed in the children lately. Then, if we have to talk about the environmental factors, then there are certain toxics that have been found to be implicated for the ADHD, including the some kind of food colorings, food additives, some kind of preservatives. Obviously, when even when we have to acknowledge the parents about the ADHD or the children having an ADHD, we would suggest them that please avoid food additives, avoid such foods having been preserved, just like the Lay's potato chips, just like the preservative foods, bakery products. We clearly describe them that you have to discontinue these practices, including the preservative juices or anything like that. All right. So there has no refined studies about the sugar levels or the glucose levels regarding the ADHD, but nicotine have been clearly found to be associated in kind of in vitro fertilization to be associated with ADHD. All right. So we have talked about the behavioral manifestations. We have talked about the DSM regarding the ADHD. We have talked about the framework of the ADHD, etiology, or the prevalence of the ADHD. Now we would be talking about what should we do or what can we do to actually manage this problem. All right. The first thing we would be talking about would be psychopharmacology for the ADHD. So in case of psychopharmacology, we suggest basically psychostimulants, or like that can be the stimulant medications. The first come in that particular medication is vastly about amphetamines, or a group of medication including the methylphenidate or atomoxetine, all right, that can be found in the name of Ratolin or uh, atomoxetine. So they are very much prescribed for the ADHD as well as for the case of narcolepsy, or you can say the hypersomnia, or the excessive day sleep. But they are also being prescribed for the ADHD by the psychiatrist. All right. So, what is the reason, or you can say, what are the effects that can be summarized in case of long-term use of such psychopharmacology or psychostimulants? Are basically they have a very much major cause regarding the arrhythmia, regarding the hypertension or CVA. That is the cardiac vascular accident or the heart stroke. All right. So they have been very much associated with that. So basically, we don't recommend, or psychiatrists even don't recommend psychopharmacology for the ADHD children's. But for certain reasons, if we have to use it, then why? All right. Basically, for the ADHD, it's been purposefully administered medications where basically you can say these medications have been lately revolutionized from psychostimulants to the non-stimulant medications also. Now, in the practice, recently, low dosage non-stimulant medications have also been accomplished, including the atomoxetine with the name of Stetra and bupropion and Adderall and Inattentive. These are few medications who are basically low dosage non-stimulant medications. All right. So these are the few medications that can be used for the management of the ADHD. Along with that, uh, students who have a very much knowledge about the psychopharmacology, I would give you a hint as well. Methylphenidates, all right, amphetamines. Those are two other groups in case of management for the ADHD. They can also be used because they are psychostimulants. All right. They can work on the dopaminergic areas, frontal lobe, and they can cause the particular secretion. They can manage that particular deficit there. All right. So they are SNRIs. All right. So what basically they do? They basically reduce the disruptive behavior. All right. They improve the interactions, and they basically work on their calm behavior. All right. They improve their goal directed behavior, or you can say they improve their concentration or attention spans, reduce their regression, obviously, making them more calm towards the group of people. So their effectivity is found to be 75% more in the children with ADHD. But they also have some side effects that we have talked earlier, including some kind of weight loss, including being inducing psychosis, including sleep problems, loss of appetite, and a lot of that. All right, including the heart stroke as well. All right. Then here comes, if we can say that eclectic approach can also be used, then what is it? Medication plus behavioral therapy. That is the MTA kind of study, where basically you can work on their suggestible behaviors to be modified, and you can basically work on their practical life very well. All right. So in case of a psych evaluation, or you can say the psychological management, what we can do, we can work on the parental training programs. We can work in the school environments and change the classrooms in a less aggressive, or you can say a very much calm environment. All right. You can remove all those particular destructible stimuli there. All right. You can work on the behavioral monitoring and reinforcement for the particular appropriate behaviors. You can work with the applied behavior analysis there. All right. Then There are certain supportive classroom structures, or you can say the certain programs have been induced lately, where basically there are certain tasks which are being uh, practice, including the brief assignments, including immediate feedback from the student or the children during that particular classroom environment. You can work on the task focused style, where basically a particular task or the short term tasks are basically being preferred and practiced, and breaks for the exercises. In the break for the exercises kind of structure, basically, we develop short term goals, and then we would be working on a particular goal. And after that, we would take some break. We would make them whatever they want. They can run around, they can just temper their you can say an unsustainable or unmanageable behavior at that particular time. But after that, they would have to recontinue their scheduled or the goal directed behavior. All right. So these were the basic treatment management regarding the ADHD. We have talked about it in a very much detail.